Okay, good evening. A very polite audience. I didn't even have to tell you to stop talking. I'd like to welcome everybody. And as you see, we're going to be talking about antibody therapies for patients with diffuse large B-cell lymphoma. What does the future hold? Which is a very exciting topic to start off the 15th International Congress on Malignant Lymphoma. So I'm Laurie Sehn from BC Cancer, Centre for Lymphoid Cancer in Vancouver, Canada, and I'll be hosting the symposium this evening. I'd like to let everyone know that this symposium is being sponsored by Hoffmann La Roche Limited. So to start things off and to get everybody familiar with using the keypad, I have a first audience question for you. And the question is, what is the percentage of Switzerland that is covered by mountains? And the options are 1, 30%, 2, 40%, is it 50%, 60%, or 70%? And you can vote now. And I have to tell you, I actually got this question wrong when I was testing it earlier. I have to say, I was surprised myself. I know it's quite hilly around here, but it's actually surpassed what I thought. The next question is, what region are you joining us from today and representing? Are you here from Europe, North America, South or Central America, Asia Pacific, Middle East, Africa, or other? Please vote now. Well, and I guess not surprising, Europe makes up the majority, but a really nice representation from a worldwide audience, which I think is exciting. And then finally, what is your occupation? Are you a hematologist, oncologist, pharmacist, nurse, pharmaceutical industry representative, patient representative or advocacy group member, or other? Please vote now. Okay, also a bit of a distribution, weighted a little bit toward hematologists. Oncologists perhaps in the minority. Okay, so as I said, I'm Laurie Sehn. I'm a hematologist and medical oncologist from Vancouver, Canada, and I have the pleasure of hosting tonight's symposium. These are my disclosures. Tonight we're really going to be focusing on diffuse large B-cell lymphoma and its current algorithm of management. I think as a clinician, diffuse large B-cell lymphoma is perhaps one of the more rewarding things that I treat in my clinic, but it also happens to be one of the more frustrating things. We know that over the course of time, we've seen a lot of progress in outcomes for patients with diffuse large B-cell lymphoma, and we know that the development of antibody therapy has been really instrumental in the improvements that we've seen. This represents data from the SEER database, which summarizes outcomes across the US over time. And if we look back to 1975, time in which the monoclonal antibodies were first created in the lab, we saw that the overall survival of patients with diffuse large B-cell lymphoma was in the range of about 40%. In 1980, some of the monoclonal antibodies started to make their way into therapeutic testing, but it wasn't until 1997 that rituximab was introduced into the backbone of CHOP for the patients with upfront management of diffuse large B-cell lymphoma. And perhaps the most exciting thing that I've seen in my career, it led to a marked improvement in overall survival, whereby we saw the overall survival increased from approximately 40% across the population to over 64 to 65% based on this instrumental change. Since that time, however, we've tried to make further advances to upfront therapy for diffuse large B-cell lymphoma, and to say it's been frustrating is a bit of an understatement. There have been several trials looking at altering the R-CHOP formula, adding in different small molecules and novel therapies, and each of those trials, unfortunately, has left us frustrated to date. And probably the last trial that was formally reported was the Goya results, which compared obinutuzumab to rituximab in the upfront therapy, and unfortunately did not demonstrate any incremental benefit. So it leaves us to ask what's next in terms of improving outcomes for patients with diffuse large B-cell lymphoma. Certainly, antibody therapy has, I think, arguably been the biggest step forward that we've seen in the modern era for diffuse large B-cell lymphoma, and it's exciting to say that there still is a lot of ongoing development in terms of novel antibody therapies being evaluated. So not only do we have ongoing evaluation of novel monoclonal antibodies, but we now have antibody drug conjugates, we have bispecific antibodies, and novel combination treatments using all of these exciting agents. So this is what we're going to be focusing on tonight. This is the overall agenda. Starting off, we're going to talk about what are the options that patients currently have in the first-line management of diffuse large B-cell lymphoma. We'll be talking about overall management strategies for patients with relapsed and refractory disease and what's coming up next as possible options. We'll be focusing on the different novel antibody therapies in development and how these might have the capacity to improve outcomes moving forward, particularly for relapsed refractory diffuse large B-cell lymphoma. We'll be discussing some of the recent data looking at polatuzumab vedotin, particularly in the relapsed refractory setting for diffuse large B-cell lymphoma, which has recently earned it an FDA approval. And then we're going to talk about looking at all of the antibodies and other treatments in development. Where do we really see the management of diffuse large B-cell lymphoma going? At the end of this session, we will convene all of our discussants tonight and have a panel discussion, and that'll give us the opportunity to answer some of your questions. I'd actually like to invite all the speakers up on stage with me for the panel discussion, and remind members of the audience that you can send questions in electronically, and we'll try to get to some of the more provocative ones. And to start off, I think I'll ask the question that is probably on everybody's mind and was submitted by one of you as well, and that is, with the data in mind that we saw today, how will, in your own clinic, you sort of weigh in CAR T-cell therapy versus this POLA-BR data in terms of management strategies? So how are you going to balance those two options, and what type of algorithm do you think you might use? Which patients might you be selecting for either of those therapies? And maybe I will start by asking Frank.
Good question. I think, to me, the most important is to combine with the polatuzumab. And of course, according to the label, the BR is the best way to do the bridging after the second line, or as a second line of therapy. So for all the patients that would fail the first line treatment or CHOP, that you can detect very easily, then you can use as a second line the POLA-BR, or maybe as a third line according to the strict label to go to the CAR T-cell.
Mm-hmm. Does anybody else want to comment on that question?
I'll just add that I think one of the challenges that we're going to face as a field is what to do with a world where we have both POLA-BR and CAR T-cell therapy. And we know, or at least we believe, that CAR T-cell therapy is most active when there's disease around, when you have enough antigen to drive clonal expansion. So if we're using POLA-BR as a bridging therapy or as a salvage towards CAR T, we may find ourselves with the desirable challenge of what to do with PET CRs to POLA-BR if it was intended as bridging, and what to do with those patients and whether or not to administer CAR T-cell therapy or consolidative allotransplant. We're going to have to clarify that.
I'm not convinced that the better situation is having bulky disease. I mean, probably in a medium, I mean, maybe in CR is not the best situation, but having a bulky disease, I agree that the data are not clear, and according to the CAR T cell, and apparently patients with bulky disease, refractory, can respond. I agree. But the common sense for years indicates that those patients with some response do better. So I'm not convinced for the moment.
This is the Goldilocks phenomenon. You want just enough antigen. You want too much lymphoma, you don't want not enough.
Yeah.
But how do you get there?
So I think that it's going to be a difficult, I guess, decision and discussion. In my own clinic, I still have very, very limited access to CAR T cell therapy, so I think that continues to be a problem. I think what I'm seeing is I try to send people toward clinical trials that we have available for CAR T. Within clinical practice, currently I still have to send patients down to Seattle, but it's really the patient who has disease out of the control that'll never make it to CAR T cells that I think, having therapies that really might offer some durable benefits so we can go on to other consolidative approaches would be valuable. Of course, this data was not tested in that way, so we have to say that we don't yet know the safety of Pola-BR as a bridge to CAR T cell therapy. But CAR T cell therapy aside, I think the other sobering fact is that the majority of patients who get CAR T cell therapy will fail CAR T cell therapy. And right now we know that that's a group of patients that, is very, very hard to treat and get any durable control over. So I think that everybody's going to probably need to balance the available options that they have in their own clinic with, resource limitations and the different mechanisms of action, but I think it certainly will lead to some interesting discussions moving forward. I'd like to throw out one question that I thought was really intriguing that came in from the audience, and that is that, in the frontline setting, we often refer to the 2-year mark as a point in time where we see the relapse rate drop, and we start to think that maybe patients are cured if they haven't relapsed by 2 years. We're now seeing 2-year data reported from CAR T. We're seeing 2-year data reported from the Pola-BR. Is that a point in time where we might anticipate that some of those patients in remission at 2 years might actually be cured from some of these options? Andrew?
I think we've got to wait and see. I mean, there just seems to be an enormous enthusiasm for CAR T, and it's all phase 2. I also have concerns about the Scholar-1 data, which is always brought out as the comparator, and I'd remind people that the performance status of patients, it was poorly recorded in Scholar-1 and varied between 0 and 4. It's always compared with Zuma-1, where the performance status was 0-1. So 0-1 does not compare with 0-4. So it's really difficult that we're being persuaded that this is the phase 2 data which has led to approval and so on. And I just don't accept that Scholar is a valid comparator for that population. Equally, you'd be mad to say that CAR T isn't an exciting and new therapy. But I really think we need to see where it is. And I think the Bender-Pola results are very challenging because, as I said, a lot more people got straight into the therapy. And there's a lot of black box selection that goes on to get people into CAR T studies. And I think it's only in the future that we'll really know how many of the people get through. If you've got really, really aggressive disease, you're not going to get all the way through to reinfusion. And when you look at the data, you have to ask, there was no bridging therapy in Zuma-1, so where do they sit in the Pola-BR data? So they're not all comparable.
Okay, well, another interesting question, I think, is that many people are somewhat intrigued by data from the L-MIND study, which is the combination of MOR208, the anti-CD19 monoclonal antibody, and lenalidomide. And one of the questions that's being asked is, given that molecule is targeting CD19, is there some concern about using that in a patient population that might then go on and get CAR T cell therapy that also targets CD19?
That's also a difficult question. When you look at the requirements in terms of CD19 expression for the CAR T cell, there is known, in fact. When you look at that, you can use that in patients for whom you had not checked that. So to me, that would not be a reason to exclude a patient from a CAR T cell program to have received a previous FC-engineered CD19 antibody.
Okay, I think, I mean, there is a lot of interest in that combination, and I think in my mind it's kind of hard to know what to do with it because we're starting to see lenalidomide perhaps not be as strong an agent as we might have anticipated. I think it's important to point out, because people are trying to make comparisons with that study and the current study of POLA-BR, and they are very different patient populations in terms of the inclusion criteria for the L-MIND study of the MOR208 and lenalidomide. Patients could not have had more than 3 prior lines of therapy, whereas prior lines of therapy was not capped in the POLA-BR trial. And importantly, patients with primary refractory disease were excluded. So I think it is a much better risk group of patients that was entered in that trial, making it very difficult to compare across trials, I think, in terms of those results. Okay, so let me see, what else do we have here? I'm gonna, and well, this is a question that I like, and that is, do I think that POLA-BR is going to be available in Canada? I like that question because it means that there's at least one other Canadian in the room. And of course, we know that right now the FDA approval has just come out. It is being examined by EMA. And we anticipate, hopefully, that Health Canada will be looking at the data as well very shortly. I guess one of the questions that's being asked is, what do we know about polatuzumab-based therapy and whether or not this could be effective therapy for double-hit lymphoma, which, of course, is a very frustrating high-risk group of patients to treat. Any comments on that?
I don't think that there are only few cases, but as I remember, there was the difference with the control arm maintained. Maybe 4 or 5 cases. You probably know this information better than me.
Mm-hmm. Yeah, so I guess importantly, we know that, for patients with double-hit lymphoma, they should definitely express the target, therefore, making this a possibly valuable treatment for them. In the data that I presented, patients with double-hit lymphoma were not excluded, but in reality, we had FISH data available on relatively few patients, so it wasn't retrieved as part of the inclusion criteria, and we don't actually have that information as to how many of those patients might actually have been double-hit. We know that in theory, it could potentially be an effective therapy, but I think moving forward, it's something that's going to need to be asked separately. Let's see. Oh, there's just a barrage of questions coming in here. I guess one of the interesting questions is, do you think the fact that POLA-BR being able to be effective for both subtypes in terms of cell of origin is an advantage? Do we think that studies targeting the individual subtypes are going to be feasible moving forward? And I'll throw that out to you, Matt.
I like to think that we're approaching the end of the life cycle of cell of origin as a relevant way to design studies. There's been a lot of a priori hypotheses that have been explored in trial after trial, trying to leverage knowledge of cell of origin biology as a way to guide therapeutic decision making, and it's been a universally unsuccessful approach. We either need better biomarkers or better trials, but I think we find ourselves now as a field at a place where cell of origin should not be driving decision making.
I think that's
I'd like to absolutely agree with that. I think it's been overdone over the years, and the UK Remodel B data didn't really show the differences in outcome that we've seen in the earlier reports. So yes, I think we should move on. And obviously there's new papers with new ways of cutting DLBCL, and we need to see how they get on. But straight GCB ABC, I think we need to move from.
Mm-hmm. So one of the questions actually in terms of biomarkers is, do we have to test for CD79B in patients receiving POLA, and what do we know about the level of CD79B? I didn't present this data, but we certainly did measure levels on all of the patients entered in the trial, and importantly, as I stated, it was ubiquitously present on virtually all patients. And when we looked at response rates according to the level of CD79B, there seemed to be no correlation. So in terms of requiring testing, there virtually is no requirement, nor was that an issue that was brought up in accordance with FDA approval. We've got only a few more minutes, but I like this question, and that is that, the data that was presented was essentially a randomized phase 2 trial, and, is that sufficient to set a new therapy as a standard of care? Do we need a phase 3 trial asking the same question? Maybe I'll comment on that. So I think, it's fair to say that this trial was not originally planned as a registration trial. So it was intended to explore the potential utility of polatuzumab in this setting. And I think what was most noteworthy was the level of efficacy that was seen, and particularly with respect to the complete remission rate and the durable response rate, and then ultimately the difference in overall survival. It really, for those of us that run trials in this patient population, it really was the first trial that's demonstrated a notable survival advantage. And, so moving forward, I think personally asking the same question in the context of a phase 3 trial, is really not feasible. In order to run phase 3 trials, you have to have equipoise in the question and the outcomes and the expectations. And I think with a level of difference in outcome here, it would not be feasible to run a phase 3 trial. And hence, I think, why this was taken forward as sufficient to allow FDA approval.
Laurie, is it worth adding to that the fact that there isn't there an expansion cohort? So I think we all know how badly the BR group would do. If we see the expansion cohort with Polar BR do as well as the randomized group, then that would add further evidence, wouldn't it?
Mm-hmm. Yep, absolutely. So I think it's fair to say that we will have more data coming from the ongoing expansion cohort. And also, I think also fair to say that, this is now being tested in the upfront setting in a randomized controlled trial. And of course, we all eagerly await those results because that trial has now just completed accrual. And that, of course, is the POLARIX trial where polatuzumab will be replacing vincristine in the R-CHOP backbone against standard R-CHOP. Okay, well with that, I think the evening is moving along. And I'm sorry if I didn't get to every question that was sent in. I think there were some excellent questions. I'm sure my panelists would love to sit around and answer your questions after the symposium. So if you want to step forward, feel free to approach any one of them. But I would like to finish up with just a couple of more questions. So grab onto those keypads again. And the question I'd like to pose is, which of the antibody therapies covered today do you find most promising in relapsed refractory DLBCL? Is it 1, MOR208, 2, polatuzumab vedotin, 3, mosunetuzumab, 4, blinatumomab, 5, the anti-CD47 monoclonal antibody, or 6, other? Please answer now. Okay, and last question, I believe. So which of the types of novel therapeutics do you find most promising for first-line DLBCL? Is it 1, monoclonal antibodies, 2, antibody drug conjugates, 3, bispecific antibodies, 4, CAR T-cell therapy, or 5, Novel combination treatments. Please answer now. Okay, I think personally they're all exciting. So just wrapping things up, when we think about first-line diffuse large B-cell lymphoma, I think right now, unequivocally, R-CHOP still remains the gold standard of care, but ultimately there continues to be an unmet need, and I think certainly this is a population of patients where we still need to find novel therapies and improve the cure rate. Certainly targeted therapies, including monoclonal antibodies and small molecules, have been investigated in combination with R-CHOP and thus far has yielded some frustrating results. But ultimately, I think we're not giving up. So we've got the POLARIX trial, which now has just completed accrual. And this, as I said, is the phase 3 study that will investigate the incorporation of polatuzumab into the R-CHOP background, replacing vincristine. So we look forward to those results in the first-line setting. For relapsed refractory diffuse large B-cell lymphoma, probably one of the most frustrating things I do treat in my own clinic, we know that anti-CD20 monoclonal antibody chemotherapy combinations really do probably make up the standard management strategies right now, but we really have very limited data comparing the current alternatives, which makes kind of treatment practices, I'd say, very variable and probably dependent on access in individual centers. Today we saw the results of the POLA-BR trial, which really was the first positive trial looking at a novel therapy in patients second line and beyond in terms of a randomized controlled trial, making it certainly a novel therapy for patients who are transplant ineligible with relapsed refractory DLBCL. Also exciting, more relatively recently, we did see the approval of CAR T-cell therapy, which was approved in the third-line setting and beyond, with some stringent criteria in terms of inclusion, but there are certainly ongoing studies now looking at it moving forward in the second-line and beyond setting. And I think quite exciting is that recently, and just within the last week, we actually saw, based on the data that you saw presented today, polatuzumab vedotin receive FDA approval in the third-line setting for relapsed refractory diffuse large B-cell lymphoma. Currently, we're still waiting EU approval. We're still waiting Canadian approval, but I think it's certainly exciting that we now have a novel therapeutic option available for this very difficult to treat patient population. So with that, I'd like to thank all of you for coming today. I think it's exciting that we're just on the verge of starting the ICML meeting. I think it's exciting that we started it off with such an optimistic outlook, and I really look forward to the rest of the meeting where hopefully we'll be hearing more exciting data about the possibilities for improving outcome for our patients. Thank you very much.